evening, everyone. Thank you for joining us. We have top national experts here to talk about what comes next in healthcare reform. All of the major presidential candidates are promising a major overhaul of U.S. healthcare, either Medicare for all or some variant of Medicare for all who want it. That is some kind of buy-in to a public program available to everyone. At the same time, if one of these candidates becomes president, they're likely to take office with narrow majorities in Congress at best. In that best case, how much bandwidth will Democrats have to remake the healthcare system, and how fast? Here to discuss how various models for sweeping reform would work, as well as more incremental steps that might be enacted by Congress and state governments, are two leading healthcare professionals, Stan Dorn of Families USA and Heather Howard of Princeton University. Stan is director of the National Center for Coverage Innovation and senior fellow at Families USA, where he plays a leading role in a broad range of projects. For more than 30 years, Stan has worked at both the state and federal levels on healthcare issues, mainly focused on low-income and other vulnerable populations. He is widely seen as a leading national expert on Medicaid, CHIP, and the individual insurance market, including the ACA marketplace, among other subjects. Before joining Families USA, Stan served as senior fellow at the Urban Institute's Health Policy Center, where he won the President's Award for Outstanding Research. Policies he's helped shape include streamlined enrollment provisions in the Affordable Care Act, express lane enrollment for children in Medicaid and CHIP, cutting some of the red tape that Republicans are now trying to build up further, state fiscal relief for Medicaid programs during the Great Recession, and legislation preserving Medicaid for families losing cash assistance under welfare reform. Heather Howard is a faculty affiliate of the Woodrow Wilson School's Center for Health and Well-Being and director of State Health and Value Strategies program, which supports state efforts to improve population health and reform the delivery of healthcare services. Heather served as New Jersey's Commissioner of Health and Senior Services from 2008 to 2010, overseeing a cabinet-level agency responsible for public health services, regulation of healthcare institutions, senior services, and healthcare policy and research. Previously, Heather was Governor Corzine's Chief Policy Counsel. She also has significant federal experience, having worked as Senator Corzine's Chief of Staff, as Associate Director of the White House Domestic Policy Council, and Senior Policy Advisor for First Lady Hillary Clinton. So without further ado, we'll begin with Heather outlining some of the candidates' major proposals.
Terrific. Thank you. Thank you all for having me. I'm thrilled to be up in Montclair, although the traffic Princeton to Montclair is not great. How many of you have done that drive? It's not great. I should start by saying that, of course, the views I'm expressing are my own. I understand you're going to give a similar disclaimer, not the views of any institution with which I am affiliated. But I'm going to jump in, and the way we've broken this up is we thought I would talk about the blue sky proposals, Medicare for all, and Stan is going to dive into sort of the build on the ACA. So, but we're happy to take questions on both, and we have worked together for many years, so I think we will probably riff off each other, but that's roughly how we divided it up. And so I thought I would start by setting the table on why are we here? I mean, why are we here, not here in Montclair, but why are we here talking about these ideas to reform healthcare? And I think there are a couple of fundamental points we want to start with. One, we're really frustrated with how many people are still uninsured, that number is 30 million, and with how healthcare costs are going up for consumers. And so those twin imperatives are coming together. And then they're leading to different ideas for how to solve the problem, but that I think is what's fundamentally underlying what we're thinking here. And then I think that third sub-bullet is, seemingly most of us have agreed that healthcare is a right, not a privilege, and that's underlying the debate, certainly what we're seeing at the national stage. So those are some core points on which probably all of us agree, even if we disagree on some of these policy proposals. And to me, is everything speaking?
There's a question from the floor.
Yes.
If it's possible to stand so you can see in the back.
Sure, of course. I don't know then if I can, okay, it's gonna test my coordination level. Okay.
That's right.
Test my coordination level, great, thank you. I hope you've been able to follow so far. So I really do think this is about, I'm just setting the table for why we're here. And what are the key issues even as we move forward from those common understandings that too many people are uninsured, that costs are too high, that healthcare is a right, not a privilege. There are real debates on the policy fine points about how quickly we want to move, what policy ideas we want to undertake, and Stan and I are roughly going to represent sort of the two polarities there. And it's not even necessarily actually where we're coming from, but we've just divided it up that way. And some of the key issues are how quickly you move, how you pay for these proposals, and who are the winners and losers, right? I mean, for those of us who've lived fought in the policy trenches, those are real issues that you need to think about. So that's just setting the table. And as I mentioned, just in the last month, we've had a release from the new census data showing that for the first time since the Affordable Care Act, the number of people without health insurance has gone up. We have been making steady progress. And Stan may talk more about this. In particular, the number of kids without health insurance has gone up. And so that's very, very troubling, obviously. And so we now have 30 million uninsured. So the ACA made a tremendous dent in the number of people without health insurance, but for all the fights about it, we have not solved the problem. We have 30 million people who are uninsured. We're the only industrialized country that has a significant percentage of people uninsured. What else are we seeing? Well, healthcare costs are going up. I know everybody in this room feels that in one way or another. It's not just in your premiums, it may be in your out-of-pocket spending. It's whether you have good health insurance or not. There's a rise in what we call underinsurance, people who have health insurance but don't feel adequately insured because their out-of-pocket costs are so significant. We've seen an increase in what we call surprise medical bills, which is when you may go see a provider who is not in network for your health insurance and you get billed the full amount of those costs. And you know what research tells us is that the unit costs we pay on healthcare, on all the different component costs of healthcare, are higher than in other industrialized countries. Our prices, a colleague of mine, Uwe Reinhardt, has anybody here heard of Uwe Reinhardt? Very distinguished health economist who passed away 2 years ago, but he wrote a seminal piece in the early 90s called "It's the Price is Stupid." And so he really believes that. And also our administrative costs are out of whack with other countries. You know, and then I like to say, you know, we in New Jersey are used to paying for a lot for things, but we think we get high quality schools, everything else, right? It's great to be here. But here we're paying more for healthcare and we're not even getting enough for it. We're not healthier. For the first time in decades, the life expectancy has gone down, largely because of deaths of despair, and we can get into that more in discussion if you want. But those are suicides and deaths related to the opioid crisis and alcoholism. And we're really not focusing. Something I work on is we're not focusing on the social determinants of health, all the non-healthcare issues that play a significant role in determining your health status. These are just some headlines that remind us of all of these. I mean, there was a great one. Healthcare for a family now costs as much as a new car. There was a column that the president of the Kaiser Family Foundation wrote. And then I think this one at the bottom is really important. The grim lottery of surprise medical bill stories. You probably see lots of stories in the news that somebody will come to a reporter and tell their sad story of how they got stuck with the healthcare bill that seems crazy. And then usually what happens is the healthcare institution usually forgives their debt. But we can't rely on the one-offs. So if you go to the press and you get some press about the horrible story. The most recent story was the University of Virginia has sued tens of thousands of patients at the University of Virginia who owed medical bills, and they've taken them to court. And even students at the University of Virginia who had bills with the medical system were not allowed to register for classes at the University of Virginia. Well, University of Virginia, once there was a light shine on those practices, is now rethinking those practices. But I don't think any of us who work in policy think that we should be litigating our policy through news stories. So this is just and then also this graph graph is just a reminder of the highest line is deductibles, how much deductibles have gone up just over the last 10 years. And workers' earnings are the lowest line. So, even overall inflation is lower than all these other healthcare costs. So the green line is family premiums, the orange line is deductibles. So our own workers' earnings are not keeping up with with healthcare costs. So the New York Times, you may have seen just a couple weeks ago, I think actually put it well. They said, is our healthcare system a fixer-upper or a tear-down? And to me, I don't know if you'd seen the Stan, because Stan lives down in DC, so he may not have seen it in the hard copy. So Stan's going to represent the left, which is the sort of fixer-upper, the different ways we could fix up our healthcare system by adding on maybe crazy additions. And then I'm going to go a little bit deeper into the one on the right, which is, well, what if we were to tear down our healthcare system and start new? What would it look like? Those are sort of, we would posit the two paths forward going forward. So what does the public want? It's sort of an interesting place to start. The Kaiser Family Foundation does a tracking poll of public opinions on healthcare policy matters, and they do the best polling on this because they are healthcare people, and they find that Medicare for All is popular when you ask about Medicare for All. Of course, as often happens in polling, that how you frame the question matters. So Medicare for All polls at a higher rate than National Health Plan or single payer. And when you present some of the trade-offs that come into play with any particular healthcare plan, support erodes. So I think if you get anything out of tonight, I hope it's just the ability to analyze what's in the news and a little bit of a more facility with that. And when you see polling data that says X support, question what the question was. And so when you talk about the negative trade-offs, like tax increases, obviously support erodes, but when you talk about the positives, like ensuring that more people have access to health care or that we've reduced administrative costs, support increases. So none of this is particularly surprising, but just to put it in stark relief, and the most popular ideas are some of the ones that Stan is going to get to present on ideas like buying in or building on the current system. It really does reflect that people, healthcare is such a personal issue, and the more you explain to people that there might be some disruption for them, that support may erode. But feel free, if you don't agree with some of these characterizations, Stan will feel free.
I agree with everything Heather always says, always.
We've worked together for many years. So here's one way I thought that might help you to think about the proposals is on the far, just on the box on the left is what's called a single payer model, where the federal government, the US government, is providing health coverage to all residents. And that would replace our existing patchwork of coverage. And Stan's going to be talking about building on that patchwork. But currently you may have slightly more than 50% of Americans have health insurance through their employer. I work for Princeton University. I have coverage through them. People over 65 have Medicare. Veterans have TRICARE. Low-income populations have Medicaid. We have this patchwork of systems, of coverage systems. And the single-payer lane, to call it that, would replace all of that with one program that is run by the government. And that's often referred to as Medicare for All, but as I'm going to get into it, there are many flavors of that. So it's important to think about this one lane, which is replacing all the current streams of coverage and having it just be one government-provided health benefit. Then in the middle lane, there's what sort of I'm terming here expansions of Medicaid. Medicare. Sorry, thank you for correcting me. But trying to get towards single payer, but being in the middle, saying, okay, we're going to create this new program that might supplant all of those previous programs I talked about, but that lets people opt out and stay in those programs if they like them. And you're going to hear that's when I get to the pages where the candidates are, that's sort of the Medicare for All who want it lane, right? So it's trying to move us towards single payer, but maintaining the current current coverage options for those who want them. And then the sort of most tentative of these three lanes, I would think, sort of the right lane here, is allowing people to buy into the Medicare program. Usually people 50 or 55 to 64. So keeping our current system completely and just opening up the Medicare program to people who are nearer to Medicare eligibility and allowing them to buy in. So, you know, the flavors here are just sort of the further left you go, the more aggressive they are towards moving towards a government program. And we'll have plenty of time for questions, but, you know, I hope that's what I'm sketching out is helpful. Here's another way to talk about it is Medicare for All is this single government-run national health insurance program. Under that left lane, there's no private insurance allowed. There's no employer-sponsored insurance. I wouldn't be getting my insurance through Princeton University. It would be through a government-run program. And as currently drafted, the proposals cover a broad set of benefits. And this is, I think, important, something we're going to want to talk about. The current proposals for Medicare for All would cover everything you sort of think about getting covered in your normal coverage now, including Medicare or employer coverage, but it would also include long-term care, which is a big gap of what is not covered by health insurance that most people have. The Medicaid program does cover long-term care, but the problem there is that people often have to spend down their assets to be able to qualify. So that's Medicare for All. Then there are these public option bills that Stan you're going to talk about. Sure. Yeah. So those are just on a high level. That's saying, okay, we're going to keep our current system, but let's get the government in as a competitor for our current system. And many of you probably remember that under the Affordable Care Act, there was a proposal to have a public option that would compete with the private commercial insurance offered by insurance companies, and that failed in the Senate. And so that couldn't get out of the Senate. The House wanted to have a public option, failed in the Senate, so the ACA doesn't have a public option, but I think the ground has changed enough that this is now one of the more moderate proposals out there is to allow a public option, which is a government-run program competing with the commercial programs out there. Then, as I mentioned, you could allow people near Medicare age to buy in, and then actually, if you couldn't do this at the federal level, you could do it at the state level, and you could allow people to buy into Medicaid. So that's just sort of I like to think about it as a spectrum. And I encourage you when you're evaluating proposals, think about it as a spectrum. And I've just pulled here some quotes from the candidates of where they are. I mean, the key polarities, which we're representing here, are Bernie Sanders saying healthcare is a right, it has to be public funded, it has to be comprehensive. That said, he has co-sponsored a lot of bills, but he is the prime sponsor and has been for years of Medicare for All. Joe Biden, his perspective is the quickest, fastest way to do it, and by that he means fix our healthcare system and get more people covered, is to build on Obamacare, to make sure that everyone does have an option. Everyone, whether they have private insurance, employer insurance, or no insurance, he's still saying you could buy onto the exchange. But he's building on the ACA, and those are really the polarities of the approaches that you see in the Democratic debate. I'll call out Pete Buttigieg that his quote is, "I would call it Medicare for all who want it," and I think he thinks he's trying to offer an alternative that says we'll build this system, but we won't force anybody who doesn't want to go into it. And then Kamala Harris has had how are you going to describe Kamala Harris? She's an evolution of her system, and I just was looking at it this afternoon, and her plan would guarantee coverage like Medicare for All, but retain a role for private insurers. I think this question of whether we're going to have private insurance is a flashpoint that's got a lot of attention in the debates. I mean, even those of us, I don't know if you understand, even those of us who live and breathe health policy felt they probably spent too much time on this in the last debate, even though we live and breathe it. It was 40 minutes of debating, churning up these same issues. To me, and this is where I will leave you, I think this is my final slide, yes, is these are the questions you need to ask is, who are we covering? Meaning, what percentage of the population is going to get covered? Is anybody going to be left behind? What benefits are we going to cover? Meaning, are we going to cover, for example, long-term care, reproductive health services? How generous are we going to be? How much are benefit? How much are the people going to have to pay out of pocket in terms of premiums and cost sharing? At one end of the scale, the Medicare for All plan that Bernie Sanders has introduced in the Senate has no premiums and no copays. So that's one end of the spectrum. The other end of the spectrum, which envisions a continuation of our current system of commercial insurance and Medicare and Medicaid, people are paying premiums and copays. Maybe there are some efforts to bring those down, but there's still some individual responsibility. How are we going to pay for this? Is a key question that we can get into in Q&A. Are we going to take any steps to contain our healthcare costs? That's sort of the hardest part of this, because every dollar in our healthcare system is somebody's income. So when we get to those cost containment measures, they're tough politically. Is there a role for employer-sponsored insurance? Is there a role for insurance companies? And then finally, it may seem minor and administrative, but how are we going to transition to this new world? And how many years are we going to give ourselves to do this? Is a key issue and a key actually point of debate among the plans. Senator Sanders' plan envisions a 4-year transition. The House bill envisions a 2-year transition, and Kamala Harris's bill is a 10-year transition. So we can get into that when we get into the Q&A. But I think, Andy, is that okay? I think is it okay to hand it over? The goal here was to give you sort of lots of things to think about, and then I'm sure we'll have a robust discussion.
Cool. Thank you. Thank you. It is really an honor to be here today. I mean, Heather and I have worked together for a long time, and she is really one of the leaders nationally in thinking about state-based health policy right now. Just really, and Andrew and I, we've sort of been crossing Twitter paths for a few years, and he is like, the stuff that we have right now with the ACA is insanely complicated. Insanely complicated. And he understands the complications probably more than maybe there are like half a dozen people in the country who are up at Andrew's level, but maybe not. So it is really an incredible honor for me to be with you today. I'd like to start with a question. How many people here are dog people? Okay, so you know when you're trying to suss out the age of a dog, you know the formula, right? This dog is 2 years old, therefore the equivalent in human years of 14, right? You multiply a dog year by 7, that gives you a human year. So since Trump I don't know about you, but since Trump has been elected, it has seemed to me that we are getting 7 weeks worth of stuff packed into every week. So you have that? I mean, basically Donald Trump has put us all on dog time. So when we think ahead to the November 2020 election, which in calendrical terms is 13 months away, in Trump doggy time, it is 91 months away, or almost 7 years away, God help us. And so what that means is it's really hard to know what's going to happen. So, I mean, obviously economy, obviously impeachment, but now I want to be clear, I'm speaking only for myself, not for Families USA. It's all personal. So the narcissistic imbecile in the White House is capable of doing anything. I mean, he could blow up nuclear bombs to destroy non-existent hurricanes to protect the people of Alabama. I mean, we could see anything. I mean, I'm exaggerating, but only slightly. You know, and so we really do not know what's going to happen between now and November 2020. So most people, and the reason why this is relevant to what we're talking about today is that what is possible come 2021 depends on what happens in November 2020. So there's this thing called the filibuster rule. How many people are familiar with the filibuster rule? Yeah, it's this really, you know, complication is the enemy of simplicity, sort of obvious. But so like you have to get 60 votes to pass most kinds of bills in the Senate. There's an exception for so-called reconciliation. If you have a budget bill that is just narrowly about budget bills, you can pass that with 51 votes. But otherwise, you need 60 votes. So what that means is, right now, if the Democrats win the Senate, but they don't get 60 votes, it will be hard for them under the existing rules of the Senate to pass any major structural change to U.S. healthcare. Single payer, another form of Medicare for all, whatever you want to do, it'll be very tough. Even if they do get a 60-vote majority, it will not be a walk in the park to get major progressive change. I mean, remember the last time we had 60 votes, I'll say we, because this is me personally, and we're here at Blue Wave, blah, blah, blah. The last time the Dems had a 60-vote majority was in 2009. And the Affordable Care Act went forward, and we couldn't get a public option put in to get 60 votes. And if we get 60 votes in the Senate, one of them is likely to be Joe Manchin from West Virginia, who's very conservative, and others are likely to be people from, pretty reddish states that managed to squeak in, on the banks of the Trumpian nuclear bomb hurricane that swept through town. So, who knows? So it's not going to be a walk in the park, but it would potentially be possible. The other thing that potentially could be possible with a big Senate majority of Democrats would be the end of the filibuster rule entirely. I mean, the short-term gains could be incredible. Supreme Court reform, democracy reform, climate change, healthcare, just immigration, just to name a few. Of course, the downside is that means that if there's a day when the Republicans run the roost, they could do all kinds of bad things with fewer checks. But if there is a possibility the filibuster rule could go away if there's enough Democrats in the Senate, which would mean with less than 60, we could do major structural change with health reform and really do some of the exciting things that we were hearing about from my friend Heather. My job is to be the Grinch to Heather's Santa Claus, and to say that if Christmas Day on January 21st, 2021 has a fair number of lumps of coal in the stockings. They're not completely filled with lumps. I'm Jewish, so it's hard for me to do these metaphors, but Hanukkah Harry, he brings socks, right? You all remember. So, if we have Hanukkah Harry instead of Santa Claus, we have socks coming in. So what do? In other words, if we have just a narrow Democratic majority in the Senate, not enough to change the filibuster rule, not enough to beat a filibuster, which means we need 51 votes and we're limited to just sort of narrow budget measures, what can we do? God forbid, what happens if we don't get a majority in the Senate at all? I mean, the smart money in DC is now saying the Dems might not pick up the Senate, or if they do, it could be a very narrow majority. The Republicans have twice as many seats up as the Democrats do for 2020, but most of those seats are in really, really deep red areas. Now, a big blue wave can turn deep red areas kind of purplish. So it is not impossible, but if we get a 2 or 3 seat Democrat majority in the Senate, that would be a tremendous victory from the perspective of conventionalism in DC. So whether we get that or whether we don't get that, I'd like to talk about what are some of the possibilities. And I think there are huge possibilities either way. So I'm going to talk federally, and I'm going to talk about at the state level. Federally, whether the Democrats get a narrow majority or not, there are going to be 2 imperatives, I think. One is finding, and this is assuming that we get a Democrat in the White House. If that happens, we can do administrative things. We can change, like a lot of the Trumpian sabotage has been done through regulations, through executive orders, through guidance, through quiet whispered conversations from DC to state Medicaid agencies. And that can all change even if Congress doesn't change. So we'll be able to do some things, and it seems to me we want to look at 2 big areas. One is moving down a better path than what we've seen in the health insurance exchanges, where it's been, sort of a fetish of free market capitalism. Okay, go into the exchange and then figure out, okay, what's the premium, what's the copayment, what's the deductible, what's in network, what's out of network, is this an EPO, is this a PPO? Oh, it just changed? I better make the right choice or else my premium's going up $100 a month next month. I mean, that's the system that we have now, and that's just like one of many levels of crazy that we have. I mean, another one is, what's my level of financial assistance? Well, let me look in the crystal ball. What will because it's going to be a tax credit that I get on my next year's tax return. So what will my income be at the end of this year? I think it's going to be X. So based on that, I'm going to get my premium tax credits forwarded to the health insurance company every month between now and the end of the year. And if my crystal ball is broken, I may owe money to Uncle Sam. That's a crazy way to run a railroad, but that's what we have. So maybe we can do some things to fix that. And in thinking about how to fix that, the state that I just am a huge fan of, and it's American health policy's best kept secret, is Massachusetts. Massachusetts has 98% of its people under the Medicare age insured. That's as good as Medicare, folks. In some ways, it's better. Don't tell anybody, but Medicare doesn't. There's a lot of seniors who don't have prescription drug coverage, even though we passed a law in George Bush time to get it for everybody. Massachusetts is doing really well on universal coverage and on cost. They have some of the country's most expensive doctors and hospitals, but when it comes to the insurance that's regulated by the state for individuals and for small firms, they have some of the most inexpensive, probably the most inexpensive insurance in the country. Eve, how do they do this? Well, they've done it, and they don't talk about it this way very much, but this is what it is. They've gone way beyond a public option. I mean, a public option says, we're going to keep competition, and we just are confident that the public option will be able to outcompete all of its capitalist competitors. In Massachusetts, they say, we are going to do a public program. If your income is below 3 times the federal poverty level in Massachusetts, you're going to go into a Commonwealth, it's called Connector Care Program. And what that means is that every health plan first of all, that means the state puts in a lot of money on top of what Uncle Sam puts in to make it affordable, so that people below 1.5 times the poverty level can get free insurance. They can get free insurance in New York too, which does something similar. But if they're in another state, they have to pay $30, $40 a month. If you are that's your utility bill, right? I mean, that makes a big difference. So the insurance is a lot more affordable, no deductibles for anybody up to 3 times the poverty level, much lower premiums, and every plan is the same. It's like those, European private insurance, but heavily regulated by the government systems, which is sort of an alternative Medicare for all kind of approach. No matter which plan you pick, it is the exact same benefits. It's the exact same out-of-pocket costs, premiums. There's no deductibles for anybody. Your co-pays, your co-insurance depends on your income. But once you know what your income is, it doesn't matter which plan you pick. It's the same thing. You just have to compare 2 variables. 1, what's my premium? And 2, what doctors are in the network, what hospitals are in the network. And so the way it works, what this has done is it has given health insurance an incredible, first of all, they built it off Medicaid programs entirely. It is the nation's most proud Medicaid buy-in program in the country, because if you want this benefit in Commonwealth, in Connector Care, you have to go into one of the Medicaid plans that they have contracted with. They won't let the other insurance companies play. It's heavily state regulated. Republican governors will keep this among ourselves, please. So and then the deal is, if I pick the cheapest plan and I say that person, working a minimum wage job, a little bit above the poverty level, cheapest plan is free. Plan number 2, if it's $20 more expensive, I pay $20 a month. Well, which plan am I going to pick? A free plan or a $20 a month plan? And the same thing, $40 versus $60. So what that means is the insurance companies who want business have a powerful, powerful incentive to charge the lowest possible premiums. So that means the super high deluxe expensive hospitals aren't in those plan networks. And the state is an aggressive regulator, so it'll make sure there's enough hospitals. Maybe you can't go to the Harvard Medical School hospital, but you can go to another hospital that has good quality ratings and it's a lot more affordable. So the upshot is, those plans that the Commonwealth Care, that the Connect Care people get, they're available to everybody in the individual market in Massachusetts. Everybody in the small group market in Massachusetts, because they are a strong regulatory state, and they've said the only place you can buy that kind of insurance is from us, from the connector. And so therefore, the great prices that they've gotten through their clever structuring of this program are available to small businesses. So small businesses all around Massachusetts buy this insurance. People, no matter what their income level is, higher income, these folks are in Medicaid plans. They may not know they're in Medicaid plans, but they're in Medicaid. What they know is they have affordable coverage with reasonable costs and good quality care, and it's something the business community loves, it's something that people in Massachusetts love. It is a public program. It is not a public option, it is a public program, and they pumped in a lot of money to make it affordable for low and middle income people. So that, to me, is just like such a sensible way to go. Now, how could we get, that's one priority. If we get a Democratic Congress, potentially we could get more money pumped into the system. Congressman Pallone from New Jersey has put forward legislation that would give money for reinsurance. We could talk about the technicalities, but there's, Congress could say we're going to put more money on the table. We're going to require, in a dream world, we could say every state's got to be like Massachusetts. I can't imagine, honestly, Joe Manchin voting for that, conservative Democrats voting for that. But to say it's an option, any state can go down this road if they want to. That would be huge. If we don't get Democrats in Congress and all we have is the administration, there are some administrative policies that could smooth the way. Massachusetts was able to do what it did because the Obama administration gave it a Medicaid waiver. Now, this administration is not going to give anybody waivers for anything public. I made that crystal clear. But a new administration could give waivers that make it more feasible for states to do this. It costs money to make coverage affordable for people, and a lot of states aren't willing to chip in a heck of a lot of money. Maybe Uncle Sam could help out either through Congress passing a law or through the administration making waivers more available. So that's one important front. But the other important front, and this, I don't know, it's maybe a little off topic, but the topic was so important, is reversing the sabotage that has taken place under the Trump administration. I think a lot of you probably know about some of the elements of the sabotage that's taken place where really junk insurance has been authorized for sale. And on the theory that, well, and they don't have to cover people with pre-existing conditions, so they can charge really hardly anything because they don't have to pay. And then if you, God forbid, you get sick, they may not pay. So that lets you be really cheap in the insurance premiums you charge. So they're really proud of that. We have to roll that back. Immigrants have been under fierce assault, as I think everybody in this room knows, and that has a huge impact on health. And when you think about children's health, preschool providers around the country are talking about things they've never seen before. Like children chewing their fingers, literally, one daycare provider talked about in the South. And in terms of just, I think it was Heather who pointed out that this recent census data showed the number of uninsured went up for the first time. The number of uninsured children went up for the second time in a row. And this is for the first time in a generation. In 1997, Senator Kennedy and Senator Hatch, a Democrat from Massachusetts and a Republican from Utah, teamed up to pass the state children's health insurance program. From that day forward, the number of uninsured kids until Trump took office went down by 2/3. And it did that in the depths of the Great Recession. When unemployment was doubling, the number of uninsured children continued to fall by 1 million from 2008 to 2010 because bipartisan policymakers worked hard to make enrollment easy, to do what they could to make sure kids kept coverage. And now, for the first time in a generation, we've seen the number of kids rise. 400,000 more children were uninsured in 2018 than in 2016. What that means is that basically from the time this evening's discussion starts until the time this evening's discussion ends, 100 children in America will lose their health insurance. And the consequences are enormous. We know that a lot of research has been done in recent years showing that lifetime earnings, lifespan, mortality rates, odds of hospitalization, all of that is changed dramatically when children have health insurance. Just from a strictly financial perspective, economists show that the government makes more than $1.50 in reduced costs for every dollar to invest in child health insurance. So this has been a real catastrophe that has taken place, and we need to reverse that. And one of the biggest causes is what's been happening with immigrants, where immigrants have felt that if they apply for benefits for which they are eligible, that could wind up getting them identified to immigration authorities and they could get deported, or they could lose their ability to legalize. And so what that has meant, among other things, is that U.S. citizen children in immigrant families who are something on the more than 15% of all children in New Jersey fit in that category. More than 15% of all Medicaid eligible kids. Those kids are not being enrolled in coverage. Their parents are pulling children and families out of healthcare, out of nutrition, out of housing programs, and it's a real serious problem. And if we get a Democratic Congress, my hope would be that we could repeal the whole public charge doctrine, root and branch. I mean, this is just, it's really, I'll just opine, it's evil. I mean, it began in the 19th century. It was used to keep the Irish out. It later on was used to keep the Italians out and to keep the Eastern Europeans out. And in the 20th century, it was used to prevent the Jews fleeing from Hitler from arriving on our shores. And now it's being used to keep Latinos out. And it's just a tool that has been used for oppression, and it's time for it to end. And we could hopefully see that happen with a Democratic Congress. If we don't get a Democratic Congress and they're not willing to take those steps, the same administrative apparatus that put that nightmare in place can retract and must retract. So that's a key priority. And then also on the Medicaid side. I mean, we've seen, they call it work requirements. It's really paperwork requirements. Or as a friend of mine, Andy Schneider at the Center for Children and Youth in Georgetown calls it weaponized paperwork. If you don't fill out this piece of paper on time, again, we know you're eligible, right? This is the age of data. This is the 21st century. We, the government, we can know what your income is, and in fact, it looks, literally, the state of Tennessee said, a bunch of people, it looks to us like you're eligible. We checked all the data. But just to make sure, fill out this 95-page form. Oh, and you have to do it in 10 days, whether it actually reaches the correct address or not. And if we don't get it back, if we don't get it processed in 10 days, you're off. 200,000 kids lost insurance over the course of 18 months in Tennessee. Similar things in Texas, similar things all over the country. That has got to change. So on the Medicaid side, on the private insurance side, on the immigrant side, there's just a huge amount of rolling back of sabotage that needs to take place. Now at the state level, obviously that means that states don't have to do, I mean the public charge issue is one that's really hard for states to address on their own. But some of these other things states can do. But it's hard. There's no money. Most states don't have money. California, hooray for them. They got money. They put it into supplemental subsidies for people with incomes too high for premium tax credits. They put it into extra lower deductibles for some people who already get premium tax credits. That's fantastic if you can do that. That's great. They expanded coverage to more undocumented immigrants. That's hugely, for a long time they've covered all undocumented children. Now they've covered some undocumented young adults. That's a huge prospect for change. But in states that don't have a lot of money, they scramble around looking for ways to make things more affordable, because affordability is the big challenge. In the public opinion research that Heather was talking about, it has shown from day one of the Affordable Care Act, the number one barrier to enrollment is people can't afford the insurance. Even with the subsidies, $100 a month for somebody who's, earning, works full-time minimum wage, that may sound like just fine for a senator, multi-millionaire senator, but for that person, it means if your boiler breaks, that's it, you can't pay for insurance anymore. And so, the way the crazy system we have, you have to decide during Christmas shopping season whether you're going to sign up for insurance. That is exactly the time of year when credit balances are worse, anxieties are highest. So what do? Well, so states are being really smart and creative in trying to figure out ways to squeeze money from a stock. So that's, I think, one of the big appeals of a public option. Because the public option, we have a Medicaid program, and actually Medicaid pays hospitals and doctors a lot less than private insurance. Maybe we can find a way to leverage that into insurance that's cheaper for that consumer and can get the consumer enrolled. So New York, for example, has this thing called the Essential Plan. Has anybody heard of the Essential Plan, seen advertisements for it on the subway? It's like up to 200% of poverty, it's $20 a month or less, no deductibles. They have signed up something like 700,000 extra people since they started offering this at a time when the rest of their exchange enrollment was level. And so they use the basic health program, a certain way to go. And Andrew has been just so clever in thinking of a million different ways we can try to squeeze the Affordable Care Act's premium tax credits this way or that way to make things more affordable. So that's one really important area of work. A second is enrollment. And New Jersey is poised to be the nation's leader on this. In Maryland, they passed a law saying when you file your tax return, you can sign up for health insurance. New Jersey has a state-enforced individual mandate. You're penalized on your tax insurance, tax form if you don't get insurance. Maybe we can find a way, instead of penalizing you, to say, if you will waive the penalty if you sign up for insurance right now. And then, instead of the craziness of Christmas shopping period where you have to weigh, am I going to pay $100 now to avoid a $1,200 penalty in 18 months? No, you're avoiding that $1,200 penalty right now. You're getting a $1,200 break on your state income tax return right now in exchange for promising to sign up for insurance. That we were looking at that in Maryland. I think New Jersey could look at it. It's really a very exciting possibility. With kids, a lot of states are looking at covering all children, regardless of immigration status. New Jersey is one of those. Some other states have done this. It's just common sense. These kids are going to grow up. They're still going to be here. Even if you don't care about humanity, you should care about what their future is going to be. We're having a much more pluralistic future than our past, and we need to make sure every part of that pluralistic America is healthy and strong. And I guess the final point that I would make is the last slide that Heather put up was so important. It was about the questions to ask. Like, the whole political debate has all been around how Medicare are you? How public are you? How private are you? As opposed to how much does a consumer have to pay for premiums? As opposed to what's your deductible? As opposed to what kind of healthcare providers can you access? What kind of benefits? How hard is it to get insurance? Does it come easily and automatically? It seems to me that from a consumer perspective, those questions are really important to keep front and center. But either way, regardless of how the next 11 dog months play out, or 13 of them, how many there are, there's a good chance, thanks to people like you all around the country, that we're going to have an opportunity to make big progress. And the only question is, how big will those steps be? And I'm excited to chat with you and this amazing panel in the next few minutes about how we can move forward.
Okay, thank you both. So there you have the sweeping and the incremental. So a couple of questions from the panel, and then we'll move on to audience questions.
Okay, the audience questions are coming
Are they, have they been, do people know that you
Most
have
people have
cards that you
cards.
can write a question on and bring?
Okay.
Okay, I'm going to ask some of our volunteers to bring the cards forward.
Yeah.
Okay, for starters, one question about sort of the basic shape of reform. First, a couple of quick definitional points. One, the candidates have branded their various plans either Medicare for all or Medicare for all who want it. Those who talk about a Medicare for all who want it are really talking about what used to be called the public option. They're talking about creating a new public program for non-seniors that would hopefully pay rates similar to what Medicare pays to providers, because those rates are a lot cheaper than what commercial insurers pay. But it's a public option, it's a different program. Second, when people talk about a public option, they're really talking about two things. In the Obamacare debate, the public option eligibility to get into it with a subsidy depended on not having access to other so-called affordable insurance. If your employer offers for affordable insurance, you can't get an ACA subsidy, and in the ACA structure, you wouldn't be able to buy into the public option unless you paid full price, which might be cheaper than private plans, but would still be very expensive. And there are a lot of proposals of bills out there that would stick with the ACA structure and not open up the public option to pretty much, quote, anyone who wants it, at least not on a subsidized basis. So the real sluice gate to transformation, short of Medicare for all, is to offer a public option on an affordable basis to anyone who wants it. So if your employer offers reasonable insurance that we consider decent now, and you like what's available in the marketplace, including the public option, you get an income-adjusted opportunity to buy that instead of your employer plan. That creates major competition of a sort that we don't have now for employer insurance. Whether it would end employer insurance or create a sharper competition is hard to say. So that much said, my question to the panel, Medicare buy-in programs or public options are often offered as an alternative to Medicare for all on the basis that Medicare for all is just too enormous a transformation to do all at once, that the economic disruption and political and administrative challenges involved in ending private health insurance may be insurmountable. And that's not just because you're talking about ending the powerful or vastly reducing the powerful health insurance industry. It's also because hospitals and doctors would be losing a gravy train. Commercial insurance pays them a lot more. So my question to you too is, these difficulties aside, is there a case for preserving private insurance on the merits? Does private insurance add value? If we did do a sort of Medicare for all who wanted plan, should the aim be to phase out private insurance, or to tame it and maintain it in kind of perfect competition with public programs? Or to just set it up and let them fight it out?
No, I'm gonna go first, all right. So first, does private insurance offer, should I stand up? All right. Now should I stand up? So, yes, does private insurance offer value? Sure. So Medicare had no drug benefits until 2004, was it 2004 that they passed Medicare? Three? Okay, so, but it went into effect in 2004. So, lots of us in the employer market had drug coverage, but Medicare's coverage, their benefits depended on a congressional statute, and it's not always so easy to pass a congressional statute. So that suggests, so there's more flexibility in the private market, so that means we could have, we have already seen newer benefits, and also different measures of cost control. So, like for me, a traditional government measure of cost control is prior authorization. We did a lot of work on the Medicaid program, and you say if you want to get speech therapy for a child, you have to prove that that therapy meets the following 6 criteria, and they're usually outdated criteria, and they deny necessary care to kids. And if you get a legal aid lawyer, like I was a legal aid lawyer at the time, you can challenge it and overturn it, otherwise you don't. And in any event, you have what the New England Journal of Medicine referred to as healthcare rationing through inconvenience, where you make it hard to get a covered service covered and it doesn't get covered. So, and the ways that, and then Medicaid programs have control costs by like eliminating adult dental benefits in much of the country, or just throwing people off the program entirely. Just really, and in the private sector, we've seen some more creative measures of cost control. Things like value-based insurance design, where we're not going to say every prescription drug has the same copay, but we're going to say those that deal with chronic illness, you can get it for free. We're not going to pay the same amount necessarily to all providers. If there's a hospital that does a certain kind of surgery a lot and they have expertise and they also do it cheaply, we'll let you go there, paying a lot less than if you go someplace else. So there is some value. That said, is there enough value that if we were to start it all over again, we would say, oh sure, let's keep the private insurance system? Absolutely not. Absolutely not. I mean, the vast majority of the extra money that they take from our premium dollar goes to executive salaries, it goes to administrative costs. The fact that you have 12 million different insurance companies, each with their own separate rules, that means that the healthcare rationing through inconvenience is so much more effective than if it's just one government agency that does it. I mean, basically, no matter which way you go, there's going to be challenges, and there are surely some advantages to a private system relative to a public, but my goodness, the advantages of a public system are just so enormous. Look at every other country in the world. Every other country in the world covers all of its people. Nobody has what we have, 30 million uninsured. And every other country in the world has much lower costs and better health outcomes and better care coordination. And they don't have, like health information technology. What a no-brainer. If you've already had a test done by your doctor and you go to the hospital emergency room, they should be able to look that up and say, oh yeah, you got a test. We don't have to do. We can't do this in this country. Why? Because we allow 1 million different medical vendors, IT vendors, to each pursue their own private profits at the expense of the rest of us. So the fact that we have a profit-driven healthcare system exacts a horrible price on us. It yields some benefits, but the price far exceeds the benefits.
I'll just add one interesting wrinkle to that, because that was such a thoughtful answer. But interestingly, if you looked back before the Affordable Care Act, private insurance tended to cover reproductive health services. Commercial insurance covered the full range of reproductive health services, including abortions. Most government programs don't.
Right.
The Medicaid program, federal law prohibits federal funding to pay for abortions. Some states, including New Jersey, use state dollars to pay. So, there are some issues which subjecting them to the vicissitudes of political decision making may not be advantageous. So anyway, as you ask that question, it occurs to me that there are some areas in which the private market was working in a more progressive way. Yeah.
Right. And the question is, who's the government? If it's state government, women in much of the country are not going to have any access to contraception or abortion. It's going to be really, really, really bad. And if it's the federal, look, wheelchairs. It makes sense to do competitive bidding for wheelchairs. If you have a bunch of different wheelchairs, do the price, pick the wheelchair. Congress couldn't get that done for years and years and years. Every time they would try to do competitive bidding for wheelchairs, the wheelchair companies that were making a lot of money would bring in a bunch of their clients on respirators or what have you and tell their story, and voila, it went away. So let's be real, the public side has its costs, but honestly, they are so much less than the private side's costs.
Okay, one more from the floor, and then we'll go to the audience.
Do you want me to hand these to him?
These are,
Oh, no, this is
one
from-
this is one.
Okay,
Go ahead.
yeah, there's nothing more. It is coming.
Parties in power have paid a big price whenever they've tried to legislate major health care reform. Democrats lost the House in 1994 after the Clinton plan collapsed. They lost it again in 2010 after passage of the ACA, most of the benefits of which had not yet, were not yet anywhere near kicking in. And Republicans got clobbered last year after a failed effort to repeal most of the ACA and replace it with something far worse. How can Democrats navigate this minefield in 2021 with all the other major problems crying out for bold action, from global warming to income inequality to child care? How much bandwidth should a new president and Congress devote to health care reform 2.0? And we've partly addressed that already. It depends a lot on circumstance.
Yeah, I mean, I'll add that I really should have a question up there that says, you know, that you should be asking a candidate not just what their plans do on these specific things, but also how big a priority will this issue be for them? Is this going to be something they're going to focus on? I mean, as we saw with President Obama, that there were opportunity costs for the Affordable Care Act, and I'm glad we did the Affordable Care Act. But after using a lot of political capital in the Affordable Care Act, he didn't have political capital for things like immigration reform and climate change. So, to me, a real question is not just what are the specifics of the proposal, but how much of a priority will this topic be for the new president, if there's for him or her in 2021? How big an issue will this be? And I think, Stan, you probably, and it's something that we talk about a lot, is so it's not just the details, but it's the priority ranking that I think matters. Yeah.
Oh boy, is that ever true? I mean, think about the last couple times we've had a Democratic president. They've had a Congress to work with for 2 years, and then that's it. And then one of the other branch went away. So the question is, if you have just a limited amount of time, how do you use it? Do you use it for further progress on healthcare? Do you use it for climate? Do you use it for democracy, to make sure that there's less voter suppression? Do you do it for campaign reform? Do you do it for reapportionment? All that democracy reform. Do you take on the courts? Do you do something like Pete Buttigieg's proposal of having a 15-judge court, 5 Democrats, 5 Republicans, they agree on the other 5? What do you take? Climate. Would we like to have a world for our children and our grandchildren that they'll enjoy living in? I mean, there's like a lot of, or unions, right? I mean, without unions, we've seen economic inequality and opportunity just dwindle in this country. No surprise. There's nobody bargaining with the boss to demand the workers' piece of the money. So, there's a lot of priorities, and, I'm a healthcare person. I've worked on it since the mid-1980s, but if I were advising a new Democratic president, I'm not sure this is where I would put my energy, is my first thought. My second thought is that we don't know, that momentum can change, power can change. We don't know what the Republican reaction is going to be to the impeachment of Trump. How is the foreign policy world going to shake out? What's the economy going to look like? We just really don't know what the world is going to look like. So based on the world as we envision it today, we might say, I would put democracy reform, court reform, climate, unions, infrastructure, I might put those ahead of healthcare. But the world could change and we could get all those things maybe. The other thought I would make about the losses, it's a sobering tale that Andrew just told. Every party that takes on a major healthcare reform gets killed in the next off-year election. Now maybe that would be different in the future, but the losses aren't just electoral; they're also in the body politics. So when the Clinton legislation went down, the support for government intervention in general diminished. President Clinton talked about the era of big government being over. No politician came within yards of healthcare reform until for more than 16 years, until 2009. So, and on the other hand, from the Republican perspective, the disaster they had when they couldn't repeal and replace the Affordable Care Act extends to public opinion. Right now, the majority of Americans believe it's the government's role to make sure that everybody in this country has health insurance. That was not the case before. So they suffered a huge ideological loss because of their failure. So the question is, how should Democrats deal with it? So my first question was, maybe you don't, maybe you do. And my second answer is, how should Democrats deal with it? Is they just have to be really smart and way smarter than me and think about the politics and the ideology and the messaging and think about what comes next and what the long-term consequences are going to be. I do not have the answer, but I know you've asked a great question.
Well, I have a lot of great questions here. Maybe we can sort of take them in short sequence. Employers, big and small, should benefit from a single payer system. Where do they stand on it? And I'd like to add something to that one thing that Heather put up there's evidence that employer insurance is kind of eroding. A lot of people who have it, most people have historically said they're satisfied with it, but there's more and more problems, more and more costs. So those two questions.
I'll start with that. I mean, because it's a great question, because intuitively it seems like employers should want to not have to worry about providing health insurance. But for many employers, it's a way they compete for employees. It's a way they can differentiate themselves. So the employer lobbies, the big firms like the Chamber of Commerce do not support these reforms. I think because also they oppose the tax, the tax provision, the tax requirements, right? I mean, I think it goes back to sort of a more fundamental view of the role of government, I think, that firms have, right? I think that unfortunately, no. So I don't think that most, you've just seen, for example, Whole Foods in the last 2 weeks announced that they were cutting back on coverage for their employees. It used to be that if you worked 20 hours a week, you qualified for health coverage. If you worked for Whole Foods, now you have to work 30 hours a week. So they rolled that back. So to your, while it would seem like as an employer, both that you would see the value of providing insurance and that you might welcome not having to do that if somebody else would do it, it's not exactly. I think you have to look at, they have other issues, their broader worldview.
Yeah, so just one state level experience to share about this. I did a lot of work in Connecticut when I was in previous jobs around efforts to do a public option in Connecticut, and we passed it, and then unfortunately we had a Democratic governor who was aligned with the insurance industry and wouldn't sign it, so that disappeared. But in the course of doing it, we've had exactly the thought that the questioner had. Employers are getting killed by health insurance costs. Wouldn't they be glad to just give it up? And one really astute person from a high-income Chamber of Commerce said, you have to act really quickly before the solidarity impulse kicks in. The problem is you have insurance companies as part of every Chamber of Commerce, and insurance agents and brokers as part of, and so if the proposal comes before the employer association, should we surrender our role and let the government take care of it? You've got all the insurance companies and the brokers saying, it's us now, you're going to be the next one on the chopping block. If you want to be in favor of a government takeover of American industry, well, you go ahead and be stupid. But don't do that. It violates it's un-American. It violates everything you believe, everything I believe. We've been golfing together. Our kids have been going to school together. I've known you for 20 years. You're not going to stab me in the back. And the solidarity impulse is very powerful. So, you would think employers would want to sign up, but they haven't yet. And part of it is the incentives that Kathy was talking about, and part of it is just sort of the worldview. And the friendships and the solidarity impulse with their poor oppressed brethren in the insurance industry. Now, as to the other point you made about ESI eroding, boy, that is so important. We did a piece in Health Affairs blog that talked about it in the context of the Cadillac tax. Anybody here familiar with the Cadillac tax? It was a part of the Affordable Care Act that said if your insurance is more expensive than a certain amount, then the employer has to pay, a fee. Basically, it was a way to make sure that employer insurance didn't cost more than a certain amount. Well, the way employers save money is that they find smarter ways to buy care. It's they put more of the cost onto the workers. And so, since the time the ACA passed, deductibles for family coverage quadrupled over that decade. And and we know, for example, if you look at workers with chronic illness covered by employer-sponsored insurance, 25% of them every year spend all their family's savings for health care. They have insurance from their employer. We know that huge percentages of people go without going to the doctor, don't fill their prescriptions, go without necessary care because they can't afford it, because employer-based coverage is putting high deductibles and high co-insurance and high co-pays. And that's really the rage at the bottom of the healthcare system. And when all the Republicans got people up in arms about the Affordable Care Act, and there were headlines about premiums in the exchange, people said, yeah, that's happening to me. My deductible, look at what I had to pay when I went to the doctor. So there is this underlying rage, and for very good reason, that's affecting a lot of people. And the policy community has not come forward to address it in any way that's at all incremental, other than Medicare for all. Now, I will once again point to Massachusetts. Massachusetts has come up with a really clever way of dealing with it, and their employer-based deductibles are way lower than most of the rest of the country because they have an individual mandate, and the mandate says you can't have deductibles more than a certain amount and meet the mandate. So what that means is if you as an employer want to hire workers, and that's why you are offering employer-based coverage, it's because it's a benefit in the labor market to you, you better make sure it meets the state standards for minimum adequate coverage, or else, your employee's going to say, what the hell? Are you giving me this insurance and I have to pay taxes for it because they don't consider it adequate insurance? So by putting that in place in 2006, they have moderated the growth of deductibles like almost no other state in the country. So, and that has gotten no attention, and it's brilliant, and it's not going to solve the problem, but it can make the problem a little bit better, and as Barack Obama says, better is good.
Okay, two questions from one person. Will all providers be required to accept Medicare for all? A short answer to that one, with the Sanders plan and the equivalent in Congress, effectively yes, because it will be the only game in town. There could be concierge service for the super rich where there's no insurance and people pay out of pocket, but there's really no other payers. The other question, related I think, is how will mental health be covered under Medicare for all, which really goes for the various proposals, and various bills do deal with that.
That's a great question, because we have enacted some laws called mental health parity laws, but we're not really there yet, where we treat mental health like physical health. And so certainly what happens in New Jersey, as many of you probably know, is we have a lot of mental health professionals who don't take insurance. And the Medicare for all would cover mental health conditions, but I don't know whether providers would be willing to accept those payment rates and be in. So we could continue to have what's really a two-tiered system where a lot of people don't really have access to mental health.
So where mental health is concerned, it's not, I was too simple, because a huge number of mental health professionals don't take any insurance.
That's right. I think the question is, we have a lot of our mental health care is provided outside of our normal insurance system now. And until we're willing to put money into the system and pay the right reimbursement rates, we're unlikely to change that.
And the same is true for dental care.
Yeah.
I mean, there's a huge gap in our country with dental care. Employer-based coverage provides just really minimal, just like a teeny bit, God help you if you actually have problems with your teeth, and Medicare doesn't cover it. Now, thankfully, Medicaid provides comprehensive dental coverage for kids, and the early and preventative screening, diagnosis, and treatment benefit, which is mandatory in every state. But other than that, we are in big trouble, and dentists don't take insurance, and so how, I think what Heather said is so important. It's all a function of money. It's easy to talk about, how Medicare is it, how private is it? Well, it's also how much money are we as a people willing to invest in healthcare? The more money, and how much is it the case that we're all going to pay for all of us to get good healthcare? And how much of it is going to be that, well, if you've got the money, you can go and get healthcare, and otherwise, God help you? That's the fundamental question we're facing in just about every arena of American life. Roads. We're going to a pothole and easy pass world, where if you've got the money, you get nice roads. Otherwise, God help you. It used to. I grew up in California. We had freeways. We laughed at people in the East who had toll roads. We had freeways. We had enough taxes to pay for the freeways. College. I went to UC Berkeley, and it was like $400 a semester tuition. Now it's what, $20,000? It's just, we have abandoned our investment in the public sphere in this country since the late 1970s, and it's come back to haunt us in every arena of life, including healthcare. So a lot of it, I think, is really about how much money are we willing to invest as a country. And, we can find, if we're willing to put in enough money, with all kinds of good things we can do. If not, it's going to be tough.
Can I follow up on that question?
Sure.
You didn't really answer, does Medicare cover mental health? Is it unlimited? Are there limits?
So the Sanders plan, the Medicare for all, would cover, but what I'm saying is that's not the only question you should ask. Is, given what our current situation is like, the fact that mental health services are traditionally outside of insurance because most providers don't accept insurance, I'm not certain that that moving to that plan would magically change that. That system is really broken, I think.
I'm sorry. So I'm a mental health professional.
You take insurance?
So I work in an institutional kind of environment where we have outpatient offices, we have IOPs, we have partial hospitalization programs, acute partial hospitalization, partial care, the whole continuum.
A lot of that's
care.
Medicaid.
A good chunk of it, we actually do take private insurance too. So there's a shift happening. The thing is it depends upon where you're at.
Yeah, that makes
So if you're up here or you're
Yeah.
in central New Jersey, you're great. You have all types of different options, and they do take private insurance. What you're more getting at more is like independent, private practice type things. Where if you see a private practitioner, chances are you're not getting the psychiatrist in the same visit either. So I would say that if you're looking for individual therapy in somebody's office, yeah, that part of mental health is just sort of a little bit outside the system, but there is a huge amount of services that actually do accept your insurance. The issue is though, is that the private insurance companies cut your time short. They have managed care,
Right.
and they don't offer you enough time or resources.
Right, so
to get the
they
help.
may be, they may be allowing only a certain number of visits, or you're only allowed to be inpatient. I mean, the same is true for a substance abuse treatment,
Yes.
that there's long waiting lists for inpatient substance abuse treatment. So, point taken, there are some really good guys out there doing good work, but not enough.
One final point about paying mental health professionals and making it more affordable. It is widely recognized that we have a huge shortage and that they're underpaid relative to a lot of specialties. And a number of the bills that are described on your sheet there, and let me add that's a two-sided sheet by the way. If they have a plan paying Medicare rates, they do say that they do bump the rates up for primary care and for mental health professionals. Maybe not enough. There's a huge financial gap, but it is recognized and it is incorporated in some legislation. Okay, next question. Many New Jersey retirees who have Medicare also have state health benefits, secondary insurance guaranteed and paid for by the state. How might these benefits be affected by current proposals? And of course, that's a huge political problem for Medicare for all. The opponents of it are, hitting on it for not letting people keep insurance that they like.
Well, it's something that Sanders has been dealing with a lot, right? I mean, unions are his natural constituency. He's progressive, they're progressive, and so he's trying to find a way to make sure that the benefits, I think where he's headed is to say that if you get better benefits on the job than we would provide through Medicare for all, you can keep that additional increment of benefit. And that's what we do today with secondary insurance. But I think it's good that people are keeping an eye on it, because if we do go down this road, it's going to be really important to make sure that workers who bargain hard for better health benefits don't lose the benefit of that bargain.
Let me answer though, I think what is a related question is, what if you were just on Medicare? What would this mean for you? And it shouldn't mean anything, but I think it's an interesting question, because it clearly is going to, I think a year from now, when we're in the throes of the presidential election, we have a Democratic candidate and a Republican candidate, that will be a big question, is what do these proposals mean? And I think you've seen that President Trump laid down a marker last week. He was in Florida, he went to the villages, to a retirement community, and the theme, I think the underlying theme was, these proposals will hurt your Medicare if you have Medicare. There's no reason that shouldn't be the case, but I think that will be the argument that is made, and it's important to note that.
Garbage. He's a liar.
Right, but there's a powerful, something we've learned in public policy is that there's the power of loss aversion. People being afraid of losing something they have is really motivating. And so, I see you're shaking your head, and I agree from a policy perspective, but I don't think we should underestimate the power of that argument to people who aren't sitting through 2 hours of a discussion about this, right?
Yeah, so I think about this in terms of a murder mystery. Like when you're trying to figure out who did it, you ask motive, means, and opportunity. So people are going to try to kill single payer, Medicare for all, whatever the proposal is. Who's got the motive? Well, industry. Hospitals are making a huge, not all hospitals, but some of them are making huge amounts of money in private insurance. So you've got hospital specialists, Equity firms now bought up a lot of practices. We're seeing that in the ads around surprise billing. In the health insurance industry, I mean, there's like huge amounts of industry would lose a lot of money, and so that's the motive. Motive, means, and opportunity. And the means is communications. We saw this in 1993 with the Clinton health reform, where it was TV ads. And anybody remember Harry and the Leagues? You know, those wonderful people that just like, you know what I mean, talking over their family's lives over the kitchen table, and it just doesn't, we have to give up our insurance, and is it what's going to happen to our kids? Maybe the government won't say we get to have the health insurance we have today. And so that's, now communications, we've got Fox, we've got Facebook, we've got, Twitter, we've got all these things. So the means of getting out that message are multiple, and the money to pay for that is enormous. So make no mistake, there will be a tsunami of cash, a true green tsunami that tries to push against the blue wave, should we ever go forward with some kind of argument. Pardon me?
And you agree that argument will be made?
So, and I think there are going to be 3 arguments that are going to be made, 2 of which are total nonsense. One is, oh my God, they're coming for your Medicare, Granny. You're going to have to share your Medicare with all those people. So that's number 1. Number 2 is, oh, the costs are going to be so much. Your taxes are going to. Well, yeah, your taxes are going to go up, but if you're buying insurance yourself, your premiums are going to go down. If you have insurance from an employer, the employer's premiums are going to go down, depending on how we regulate. You may actually see some of that in your paycheck. Like, money is money, whether it's a premium or a tax dollar, it's money. But we know this argument is powerful because it was used, it stopped single payer in Vermont, it stopped single payer in Colorado, heard it in California. So we know we're going to hear that those 2 arguments are just nonsense. The third one has some truth to it, which is you're going to have to give up what you have today in favor of something that we think is better. And as Heather said, there's laws versus risk. Even if I think, well, yeah, Medicare is better, this will probably be better, but it's easy for me to get scared when it comes to health insurance. So those are going to, if we do go forward with Medicare for all or single payer or anything like that, rest assured you're going to see commercials with those 3 themes. You're going to see Facebook ads with those 3 themes. It's going to be a big old torrent coming at us, and we're going to have to figure out an effective way to fight it.
Okay, a couple more. At close to 8:45, we wrap up. If anyone wants to stay for.
People are reaching their hands for
Yes, I know.
We have to be out of here.
We have to be out by 9, but we can, we can go close to that. We'll give people an opportunity to leave in 5+ minutes. Question, can you elaborate on cost control possibilities under various plans? We've talked a lot about public options, which might pay something like public rates.
That is the main one that they're talking about, is just reimbursing healthcare providers at a lower rate and pegging those, because in our current system, commercial insurance pays providers, and by that I mean doctors and hospitals, higher than Medicare pays, generally speaking. So it's a hard, and so the argument is that we'll just push down those reimbursements. Now you can imagine how that's easier to say than it is to do. That's somebody's income, right? And that's sort of I think that doesn't get enough attention, that question of that assumption that we could just do that, because I think that reimbursement rates, the current system, if you're a hospital, you've got different payers paying different amount, and you're shifting your cost depending on who's paying you what. And I think there'll be a lot of objections probably based on that, right?
Yeah, I think that's right. I mean, and it's all about market leverage now, right? I mean, some hospitals don't get paid all that much in the private, for private insurance. Others get paid. I'll tell you a story again from Connecticut. So Yale New Haven Hospital, it's a nonprofit, it's a charity. It's a charity whose executives make millions of dollars a year because they do such wonderful charitable work, and they have to be. And so they say to insurance companies now, if you would like to sell policies within a 50-mile radius of New Haven, I assume, right? So that means you need my hospital in your network, otherwise no employer is going to buy your policy. And so if you want my hospital in your network, you're gonna have to pay us absolute top dollar rates, and you can't apply any of these cost containment measures, and you just have to like write us a big check. Oh, and by the way, we just bought up all these other hospitals around Connecticut, and if you want us, now we know you don't care about the Norwalk Community Hospital we just bought, or the Bridgeport hospital we just bought, and you don't need them in your network, but you need me in your network. And if you want me in your network, you have to pay them what you're paying me, absolute top dollar, and they do. So some hospitals are not doing great, other hospitals are doing fabulously well. It's all about leverage. We're seeing waves of mergers like nobody's business because they all understand it's all about leverage. So, Medicare pays a cost-based reimbursement level. So, we could say no hospital gets to charge more than twice the Medicare rate, and you ought to be able to do well enough with that. But, hospitals employ a lot of people, they deliver a lot of babies, including of legislators. It's like really tough to go after those guys. You'll notice that Bernie Sanders is not going after hospitals.
Even though I would just add that several presidential candidates have talked about
just
ramped
started
up
breaking
antitrust enforcement, for example.
And then the other example of cost containment is prescription drugs, obviously, where we have government. Well, I'm just going to control myself here. We have government-conferred monopolies that enable exorbitant prices to be charged, and we're getting lousy innovation for it. It's like literally 8 out of 10 new drugs are just variations of old drugs. Less than 1 in 10 offer any clinical value whatsoever. But they have monopoly power granted by the government. It's a matter of life or death. It's like selling water in a town where the water mains have all broken, and you're the only one that can sell this life-saving water, and so therefore you can charge all you want. And they do. And so that's a way we could save some money. And I'm not talking on my Family's USA time. I'm just expressing my own personal views as a pissed off American citizen.
Okay. A possible problem with a fixer-upper approach, short of Medicare for all. The sicker patients will choose the public options, leaving the programs underfunded. We need everybody in, nobody out. That's how insurance should work. Wouldn't increase in taxes to provide Medicare for all be less than current premiums people are paying?
Yes, it will be less. But it's complicated when you think about people with illnesses. Right now, there are a lot of Blue Cross Blue Shield plans that are making a lot of money off the chronically ill, because they've got this thing in the back room called risk adjustment, where they vary the amount of money the plan gets based on the characteristics of the enrollees, so that if you have a lot of people, like for everybody with diabetes, you get a 40% bump in the amount that you get, and all the plans in the state get into this pool, and those with more expensive people get money from the pool, those with less expensive people put money into the pool. So right now we actually have a lot of Blue Cross Blue Shield plans, many of which are like PPOs and are relatively high premium, that have a lot of folks with chronic illness who would be unlikely to depart for a public option. So the world is complicated.
Okay, let's make this the last one before our closing statement, and then maybe we can go another 5-10 minutes. Current Medicare is highly dependent on private supplemental insurance, both private Medicare Advantage plans and Medigap plans that go with traditional Medicare. And for current Medicare, the only prescription plans are private. So Bernie's Medicare for all is purely public, but we have a hybrid system now. Can you comment on that and how that fits into the picture of where we go next?
Sure. Yeah, that's really right. Only 12% of Medicare beneficiaries are in classic Bernie style, in Medicare classic. Pure single payer, no extra health insurance. And even there, who pays the claims? Private insurance companies. Each region of the country has a private insurance company that pays the Medicare claims. So they get paid on for administrative services only. But you heard me allude to this theme earlier. The question of how public is it is not an easy question to answer. And it's just such a shame that that's where the political dialogue and the press conversation is all gone to, like, because Medicare now has a lot of private insurance. Is it private, is it public? I described to you a Massachusetts program that has private plans, but they're conforming to public regulations, and they're all built off the Medicaid infrastructure, which was based on a system of administered prices that were publicly determined, but it's private entities that are administering. It's very complicated. And really, I think we ought to be, I mean, this is my own personal view, we ought to be focusing on sort of much more consumer-focused issues. Who gets covered? How hard is it to get covered? How expensive is it? How much does it cost when you go to get your healthcare services? What services are covered? If we get those questions answered right, and also, what are we paying? You know, are we paying outrageous amounts of money for way, you know, like right now, it's not just about the consumer side, it's about the payment side. We have, I mean, being in the healthcare industry it's not about health, it's about industry, it's about making profit. There are exceptions, thank God, but there's a lot of our money is going to stupid uses, and can we bring that under control is the other big question. But I don't care how public, how private, how mixed it is. If people are being treated well, and if the taxpayers aren't being gouged, then I'd be happy.